Hello, my name is Vanessa. Today I'm going to be presenting a psych case on an adolescent, 16-year-old with initials of CR. The patient is a 16-year-old male presenting for a follow-up related to ADHD, depression, and anxiety. He has no history of prior psychiatric diagnosis, but his mother notes a chronic pattern of sensitivity and poor peer relationships. During the past 3 months, he's lost interest in spending time with his friends. He has steered away from going to social activities and has difficulty falling asleep and waking up early. The patient complains he has low energy, low concentration levels, and feels hopeless at times. He supports his worry regarding academic performance, particularly when he's getting close to taking an exam and he has fear of failure. He reports restlessness, racing thoughts, an inability to relax without reported panic attacks. He's also began to skip meals. He doesn't report any significant weight loss, but does report about 5 pounds of weight loss over the past month. He denies any suicidal thoughts or behaviors and concurs with the holding of passive thoughts of not wishing to be alive sometimes. He does turn to journaling and music and some coping mechanisms, but it's not long lasting and it doesn't seem to help anymore. No past psychiatric history, although the mother states that he's always been anxious as a child and always overthought things. No history of substance abuse, denies alcohol, denies tobacco. Medical history, he's otherwise a very healthy adolescent, no chronic illnesses. He's up to date on all his vaccines, and then no history of hospitalizations or surgeries. No current medications at the time of the visit, no allergies. Family history, mother does have a generalized anxiety disorder, which is managed with an SSRI. The father is healthy, and he lives at a home with both parents and two younger siblings. He is a 10th grader in high school, which he attends in person. No involvement of sports or extracurricular activities. And although he did previously play soccer, he dropped out due to lack of interest. He doesn't hold a part-time job, and no known sexual activity. Doesn't report having like any romantic or sexual relationships. In regards to review of systems, generalized, he reports fatigue and low energy. For heat, denies headaches, visual changes, sore throat, or nasal congestion. Skin is intact, no rashes, bruises, or lesions. Cardiovascular, denies any palpitations or chest pain, nor shortness of breath or cough. No issues with abdominal pain. Does report like mild constipation. Genital urinary, no dysuria, no hematuria, no frequency. Neurological, no dizziness, seizures, or syncope. Musculoskeletal, no joint or muscle pain. Hematologic, no bleeding issues. And endocrinology, no heat or cold intolerances. Psychiatric, he does report like low mood, excessive worry, sleep disturbance, and low self-esteem. In regards to physical examination, his general appearance, he's quiet, cooperative, maintains eye contact. His vitals are within normal limits. Everything else is within normal limits. Again, going back to psychiatric, his mood is sad and anxious. His thought process is logical and goal-oriented. His judgment is intact. His speech is soft, slow, but a normal rate. And he is alert-oriented ×3. We did do a PHQ. Just sitting here, PHQ 9, which was 15, showed moderately to severe depression, and then GAD 7 was a 13, which comes up to be to have moderate anxiety. Primary diagnosis was a few primary diagnoses were major depressive disorder with also generalized anxiety and ADHD. Differentials included adjustment disorder, bipolar disorder, hypothyroidism, and iron deficiency anemia. We did initiate sertraline 25 milligrams daily with plans to titrate, and melatonin 3 milligrams every night for sleep. He was also referred to a CBT and encouraged to continue journaling, having mindfulness, and initiated a school-based support evaluation for academic accommodations. Family therapy was also recommended. Labs were ordered to rule out reversible causes such as hypothyroidism or anemia, and then a follow-up was set up for 2 weeks. I feel like this case was meaningful to me because I do have kids that are in that adolescent age, and I feel like with social media, having so much influence and the difficulty of being a child nowadays, I feel like it's really hard, and I'm always so scared and cognizant to the way that my children are feeling. And so I just took a special gravitation towards this case, just because I saw how it took a toll on the mother and how that was really hard for her too. It also stood out because it required me to navigate multiple mental health conditions that were essentially interconnected. I feel like just treating one symptom wouldn't have been enough. So it was the depression, the anxiety, the ADHD, and the insomnia that were just feeding all into each other. I had to integrate pharmacological and non-pharmacological strategies, manage potential side effects, and keep in mind the emotional and developmental needs of the adolescent. This did force me to think beyond a textbook, and then see the person as a whole. I did apply the DSM-5 TR criteria and the AACAP guidelines and peer-reviewed literature to my guided decisions. The screening score supported MDD and GAD. The ADHD explained the ongoing concentration problems, and his positive response to journaling suggested some resilience. Bipolar was ruled out due to no manic history, and adjustment disorder was less likely given the chronic nature. And then the sertraline was chosen for its safety and efficacy in adolescents and co-occurring depression and anxiety. And then melatonin was also chosen for sleep because it's non-habit forming, and he's still a child. I did use Gene Watson's curative factor of building a helping, trusting relationship. I feel like that's really important with any age group, but especially this one. I listened without judgment. I validated his feelings and ensured both that he and his mother were involved in the decision making. We addressed emotional well-being, school stressors like social withdrawals, and family communication, not just the symptoms that were going on. Culture sensitivity was respected by pacing medication changes at the family's comfort level. I encouraged journaling, positive social contact, and worked with getting him some school resources to move any barriers that he might be having. And then this approach also blended not only science with empathy, and aiming not just for symptom relief, but for personal growth and restored connections. I feel like it's important, again, to integrate everything into this, especially with adolescents going through so much. And I feel, I just felt connected to not so much how the mother was feeling, but sort of put myself in her shoes and, feelings, and just thought about how I would like to see it handled. Thank you for listening to my presentation.